Good afternoon everyone. Today we are going to discuss about principle of end of life care. When we talk about the principle of end of life care, we will talk about the component of good death. We will talk about what could be the strategy for providing good end of life care and what are the ongoing new implications and new laws and what are the barriers in providing end of life care. So this is a very brief description. But let me discuss here, which is very important, that we have to distinguish between three different terms, that is palliative care, end of life care and terminal care. So to provide high level of end of life care, there are certain strategies, there are certain process which we need to follow. These are known as core principle of end of life care. So let me start. So I'm Dr. Avinash Tiwari. Presently I am working as a lead consultant pain, palliative medicine and supportive oncology at Sanjeevani CBCC USA Cancer Hospital, Raipur, Chhattisgarh. So let me start with certain data which was published in Global Atlas of Palliative Care and End of Life 2020 by World Hospice and Palliative Care Association. Earlier the first edition was published in 2014. So now we have the recent data about how the things has changed over a decade. So 31 million people and 25.7 million near end of life worldwide required palliative care in 2017, which doesn't have much difference as we compare it to 2014 data. Out of 1 lakh population, 993 patients in low and middle income country need end of life care, palliative care. 76% of adults and more than 97% of children needing palliative care at end of life belong to low and middle income countries, including our India. Over 55 million people died in 2019 and the vast majority died in low and middle income country without even basic access to palliative care and end of life. If you talk about the need of palliative care and end of life, there 28.2% the bulk of issues are related to cancer, approximately 22% with HIV/AIDS, 14% with cerebrovascular disease, 12.2% for dementia and schizophrenia, and rest are other miscellaneous causes, both communicable and infectious disease. So what exactly the scenario is in India? In India, 1 million new cancer patients every day and 80% are with stage 4 disease, in which the utility of the disease actor treatment is less and the need for more of quality of life directed and disease control directed treatment is more. So the emerging elderly population in our India has caused an immense need of palliative care and end of life care facilities in our country. And there was a data from August 2020 by WHO that less than 0.4% of patients with end of life have access to morphine. So the scarcity of availability of morphine is also a barrier for a good end of life. So there was a report which was published by the Economist, the Lancet publication in 2015, which was later revised by 2021. So it says the in quality of death index, we are far behind many countries, even poor countries, with means low income countries, and we were standing probably I think our rank was quite below including other developing country. But in 2021 we ranked 67th among 80 countries and 14 out of 21 low income countries. So we can imagine where we are in quality of death index. Although the parameter used in 2015 and the parameter used in 2021 are different, but still there is a far way to go as far as the end of life care policies and its implementation is concerned in India. So death and dying in India it is very under recognized and very less discussed topic as far as the public health and the political will is concerned, but we have certain data over last few years. So 83% of healthy Indian population prefers to die at home, but mostly they die in hospital because of the poor access to the community-based palliative care and even the hospital-based palliative care. More than 80% of the healthcare spending is out of pocket, mostly in end of life, and that is why one of the reason that we have the poor quality of death index in the Lancet report. 78% of patients with advanced illness in end of life left ICU against discharge left against medical advice, and almost all these lama patients die in misery and with a lot of suffering because they don't have access to proper symptom relief in their end of life period. And the decision taken unilaterally by the family, because when the patient can have access to proper palliative care, the decision will be more of shared. So most of the lama decisions are basically unilaterally. To know when death is coming is a very important component of good death. So let me discuss one by one about what are the principles of good death. So when we talk about the principle of good death, I will suggest you to read a paper by Smith and Orr, Principle of Good Death, in British Medical Journal in 2000. So what exactly the principle of good death involves? It involves the ability to know when the death is approaching. It involves access to proper symptom control, physical symptom control. That should be that is the main core principle of good death. It encompasses patient-centered need, and we have to ensure that these kind of needs are being met. The principle involves right to die in a dignified manner and at a preferred place of choice, and without needlessly prolonged with artificial means. And patient must have control over what is happening. Their privacy, their dignity should be maintained. They should have the access to information, both for the patient and their families, access to expertise like specialist palliative care department, when necessary access to spiritual and emotional support also, and there should be access that they should be able to issue advanced directives. So these are the core principle of good death. In a short, I will define it as the sense of control, the sense of dignity, and the sense of privacy. So we have discussed about the principle of good death. So what are the steps involved in providing good end of life care? So I will suggest you to read the Stenhauser In Search of Good Death 2000 article and Chapman L. et al. Care in Last Hour Dying of Life 2011. So these are the good read about the component of good death. So there are certain precise steps involved in providing good end of life care or good death. So one should have a competency to recognize the dying process, because recognizing dying process, it's biological phenomena, it's physical phenomena, it's psychological, it's physiological, it's social, and it's spiritual, and it's familial. These are the certain markers which one should have the competency based training for recognizing dying process, because discussing about end of life care will be too distressing for the patient, for the families, for the hospital facility, for the healthcare professional, and for the treating physician. So one can't miss the set of skill that they should be able to recognize the dying process. And what are the markers of dying process? A biological marker, physical marker, psychological marker, social, spiritual, and family marker that we are going to discuss ahead. And patients should have access to proper decision making and communication. So both the patient and family should have access to the expertise of communication specialist in a palliative care team, and they should have a sense of governance over decision making. So one has to identify the appropriate surrogate if the patient is not in the decision making capacity, and must facilitate end of life care decision making. So one should identify the decision maker, the time of decision, what has to be precisely decided in the discussion meeting, what will be the strategy for transition of care, and what will be the exact component of end of life communication, like what could be the life expectancy, what are the future trajectory symptoms, what could be the documentation, how you are going to facilitate advanced care planning, and the discussion about the prognosis of death and the process of dying. So these are the main component of communications. And third step involved in providing good end of life care is the ethics of end of life care that must be ensured time to time, and that has to be monitored and reviewed time to time. The fourth step is initiation of end of life care process, and this initiation of end of life care process must be reviewed time to time. There are certain end of life care pathway which guide us to set a criteria to initiate the end of life care. The certain clinical criteria must be met, certain agreement must be met, and certain symptom criteria must be met to before initiation of end of life care or end of life care pathway. Then it comes the process of end of life care. Means you should be able to recognize the active symptoms, active process, the physiological and non-physiological component of a dying process, what could be the anticipatory symptom, and what are the ongoing symptoms. So one should have the initiation assessment, one should have the ongoing assessment during the process of end of life care. Then it comes the process of end of life care. Then after that we have the after death care, which we are going to which we will be discussing in upcoming slides. And there are certain to-do list when we discuss about the review of care process, and lastly but not the least, bereavement and care support, which is a very important component of step involved in providing good end of life care. That is the core reason we say that in palliative care we don't leave family and carers abandoned. We should also join their journey even after the death of the patient and provide them a support during their grieving process in form of bereavement care support. So there are certain markers, there are certain set of symptoms, and there are certain set of sign which tells you about the recognizing the dying process. So we are not going to go much in detail about these things. You can have the read with the reference I mentioned you, but one should not miss the general indicators of decline and increase in need of end of life care. That can be general decline in physical condition, increasing dependence, need of support, repeated unplanned hospital admission, advanced disease, stage 4 disease with complex symptom burden, presence of significant multiple comorbidities along with advanced disease, decrease in the physical performance score, which you can measure with ECOG performance scale and palliative performance scale, decrease in response to treatment with the best possible optimal treatment, the patient is not responding well, that can be one of the indicator, and decreasing in the reversibility of the disease also is one of the parameter. And if the patient choice for no further active treatment and focus on quality of life, if there is significant amount of cachexia, like significant weight loss that is more than 10% in past 6 months, known as refractory cachexia, if you identify any sentinel event like a fall or multiple transfer to nursing homes, if there are certain recent advance, there are certain biological marker also, like the significant drop in the level of serum albumin, although there is no clear-cut evidence for that, but there are certain there is not single indicator. It should be the spectrum and the clubbed indicators which should be taken into the consideration rather than just one indicator. So these are certain the process one should be able to recognize when they think that the dying process has started. So the main component, or there are certain priorities of care dying person and their families should be provided, and the end of life decision making and communication is the one of the major component or the principle of core principle of end of life care. So one has to identify the decision makers, and the decision makers should be identified on the basis of Human Organ and Transplantation Act, which was amended in I think 2021, and one should able to recognize the proper surrogate, the most legal surrogate who can be the decision maker. If the patient is decision making capacity, yes, he can be on anticipatory basis can be part of this process, but that has to be very well documented, and it is called as advanced care planning. So the primary treating team in collaboration with palliative care team can start this process, and this decision making process should be consensus decision, not an individual physician's opinion. So there should be a set of physician who should come to a common ground and a shared decision about the what exactly they want to implement for the particular patient. This is known as consensus decision making. For the how the consensus decisions are made, you can find in AIIMS New Delhi I think 2020 guidelines about how the consensus decision should be made. So what could be the exact time of decision, when to consider the timing, what could be the appropriate time when to consider this end of life care communication? So there might be generalist and specialist consideration about the timing, but there are certain the biological indicators that actually triggers you about the timing of decision. Like if the patient is having advanced stage 4 metastatic cancer and not responding to optimal treatment, with a gradual decline in poor performance scale and uncontrolled symptom and cachexia and lack of reversibility. So this actually gives you the trigger about the timing of decision. There could be certain other ongoing process like multi-organ dysfunction, unresponsive to reasonable period of aggressive treatment. That could be one of the other co-factors in deciding the timing of decision. So end of life decision making is a process rather than a step, and communicating the decision in a very sensible way is very important. It should be the honest and realistic prognostic discussion. It should be the open-ended with consistent information, and one should not give unrealistic hope and promises during this process. And the shared decision making is a very important component as far as the communication end of life is concerned. Transition of care from disease-directed to the comfort-directed treatment, this communication is also very tidy. If we talk about our clinical practices, the transition of care is very what I personally feel is very difficult when we talk to the patient and their families about that they will be mainly on the comfort directed treatment rather than disease directed treatment, and it should encompasses certain prerequisites, and this all principle we are discussing over here can be extrapolated for this type of care also. So communication on cessation of disease specific therapy, change in focus and goals of treatment, or introduction or escalation of input from palliative care and non-abandonment by the primary caregiver are the important component when we talk about the transition of care. So here then it comes the key components of end of life communication. One should have this try to incorporate this 5 major component of end of life communication subjects. Like there should be a subject on discussion about the life expectancy discussion, discussion about the future symptoms and their management, and discussion and DNR documentation, or whether to allow the natural death, advanced care planning, and disease process of the disease trajectory, its associated symptoms, and that a part of discussion on the process of death and dying, how it happens. Although it might be very distressing for the carers and surrogate to be part of this step, so it's not mandatory that you discuss all these 5 subject all together. You can take one by one topic in gradual timings. So there are certain ethics of end of life care, like in other clinical practice. It is also applicable in end of life care, and the ethics of autonomy, beneficence, non-maleficence, distributive justice. This all are co-component of ethical decision making. So when you shift your practice from medical decision making to ethical decision making, I think these are the 4 core components of ethics of end of life care, and it is applied all over your practice, not just end of life care. So initiation of end of life care, that there are certain, as I discussed previously, there are certain clinical criteria, there are certain agreements, there are certain symptoms criteria. So the clinical criteria we have already discussed, like stage 4 disease or advanced disease, not responding to optimal medical line of treatment with poor performance status, and reversibility of disease. So these are certain clinical criteria. And there are certain agreement, like the consensus among the treating physician and the family physician, and certain directives in form of certain documentation, or there are certain prerequisites about the result of progressive and irreversibility disease, so and its complication. So there should be certain agreement criteria is a part of consensus based decision making, and symptom criteria, in which you can say out of 4 symptoms should be positive among 7 different criteria which has been mentioned over here. These are the semi-consciousness or comatose patient, or unable to take oral medication, mostly confined to bed or almost confined to bed, unable or lack of interest in food or fluids, no response to question, and no spontaneous verbalization, detached from surrounding, and failing vital parameters. If 4 out of this 7 are positive, means it is a set of symptoms which actually ask us to start end of life care. So the process of end of life care, basically the gold standard framework, United Kingdom actually guide us. There has been many end of life care pathway which are now obsolete, like Liverpool care pathway. What is gold standard framework, United Kingdom says, are the most followed process of end of life care pathway. It actually gives us 6 principles of providing process of end of life care, that is identification of end of life care, and need of patient, and need of family, and assessment of the need, those needs, planning of end of life care, and executing the planning, and means ongoing assessment of end of life care, and reassessment and reflection on your process, because that will strengthen your help in the providing further end of life care. So the reflecting in end of life care is very important. So this is known as gold standard framework, United Kingdom, and this is these are not steps, these are actually process. and there has to be certain guiding principle. When we follow this process, the symptoms should be well controlled, patient should be at preferred place of care, like what we discuss in the component of good death. This all component should be followed over here. We have to look among the family where they are prepared, they are educated, and they are supported timely. At the same time, we have to reflect on team accepting, anticipating, and whether they are providing a good end of life care or not. So there are certain set of symptoms which are common in end of life, like pain, dyspnea, delirium, and vomiting. And these symptoms will be discussed in detail elsewhere, somewhere else by another expert. But I want to discuss a brief about this symptom management. Like the pain, there should be a background, well-controlled background pain, and there should be availability and accessibility to rescue doses also. And remember, unconscious people experience pain, so one should recognize the pain in non-verbal patient also. There are different screening tools, there are different tools to recognize that, so that we can discuss somewhere else. Dyspnea, this is one of the major symptoms in end of life care, and the answer is oxygen and the fan, and the use of opioids and benzodiazepine, and that differs from one setting to another setting, cancer to non-cancer. Delirium is also not uncommon, and one should have access, that palliative care team should have access to the antipsychotics with IV infusion facility or subcutaneous infusion facility or benzodiazepine, and certain non-pharmacological strategies like environmental changes and correcting the correctables. Vomiting, IV antiemetics we are going to discuss in upcoming slides. Whenever there is refractory symptoms for these common symptoms, you can start palliative sedation with certain prerequisites. So what are the common issues when we talk about the end of life care symptoms? Respiratory secretions, hydration, especially counseling of the relatives, and the care of skin and mucosa are also common issues one encounter when providing end of life care. Respiratory secretion, which were previously known as death rattles, now this term has been obsolete, can be minimized by optimizing hydration, giving good nursing care, and using anticholinergic by subcutaneous or IV glycopyrrolate. Hydration by judicious use of deciding about the pros and cons about the IV of subcutaneous hydration, and the skin and mouth and eye care that has to be reflect and review time to time by specialist nursing team. What are the psychological support to the family which is required? They require your time, they require privacy, sometimes they need special kind of help in form of counseling, and some when they feel they are spiritually compromised, they can have access to chaplains. They should have logistic support that will reduce their logistic burden and will ensure some form of peace to them. And when needed, identifying the high risk of bereavement is very important, and executing those bereavement support is also very important. So let me talk about the palliative sedation. As we discussed, there are certain common challenging symptoms in end of life care when it becomes refractory, and when our intention is, if one should not, this intervention should not cause death. So the medication induced sedation, that is aimed to not intending to cause of death on a background of refractory to the common symptoms which are intolerable in your eyes, in the carer eyes, in a background of advanced and incurable disease which is showing irreversibility, and when the death is imminent, that is hours to days, you can start palliative sedation with proper documentation and following the process of end of life care. Let me suggest you certain studies which actually tells you how burdensome the symptoms are in different clinical setting. And you can see over here that delirium, dyspnea and pain. These are the three cardinal symptoms which actually require palliative sedation. So when to consider palliative sedation? If the symptoms are refractory to pharmacological and non-pharmacological optimal options, if the patient's death is imminent, like in days, hours, days or week, additional treatment are unlikely to bring relief to the patient. If the patient aggressive palliative treatment has failed to control symptoms, if the sole goal of the care is to relief of distress and symptom, and if there is not enough time to try a potential non-sedative approach in a case of impending death. So that a certain criteria should be met before considering palliative sedation. So prerequisite of palliative sedation are more or less same to end of life care, what we have discussed earlier in previous slides. Communication, proper informed consent, documentation of the initiation, and the initiation process should be like same of initiation of end of life care. One should all cross check all the previous record, and they should be identify all the correctables on a background of corrected medical condition. Failed aggressive palliative care interventions and consensus among the treating physicians are there, then these are the prerequisites of palliative sedation. So there are certain steps. Okay, on what level you should prescribe what drug. Step 1, 2, 3, 4. If the patient has to be started on anxiolytic and sedative like haloperidol and midazolam. Step 2 is the use of levomepramycin and chlorpromazine if not available. Step 3 will be these are the patients who are stupor, and these patients need to have increased sedation, and certain general anesthetic agents are used in such setting like phenobarbital and propofol. Some also use dexmedetomidine, and in a coma patient just monitoring of the deep sedation is required, and is a synonymous with palliative sedation. What in palliative sedation you actually induces the deep sedation, and in stage 4 step 4 they are already in deep sedation. So the palliative sedation have the stage of anxiolytic and sedative. Step 2 is drowsiness, step 3 is stupor, and step 4 coma, means the optimal palliative sedation has been achieved. So the drug and doses of palliative sedation, this is the slide. You can take a screenshot or you can save this slide, and these are the common doses we use for the different drug. Majorly we use midazolam, haloperidol, chlorpromazine, dexmedetomidine, and phenobarbital and propofol. So after the initial assessment, there should be certain ongoing assessment, and there are certain goals which should be 4-hourly assessed. There are certain process which should be 12-hourly assessed. What are the 4-hourly assessment? The pain, restlessness, respiratory secretion, presence of vomiting, breathlessness, the oral moisture or the dryness, urinary issues, and the medication, that should be assessed 4-hourly. Then there are certain 12-hourly assessment like positioning of the patient, bowel and bladder issues, psychological and social support to both patient and their family, religious and spiritual support to both patient and family, and need of the family address, like family is satisfied with your services or not, where they are aware of the ongoing condition and treatment or not, whether they are aware of the nature and extent of the disease and goals of care or not. So there are certain 12-hourly assessment. Then there are certain after death assessment, like where the primary team has been informed or not, whether the body has been laid appropriately or not. This is very important. There are certain procedures after that has been followed or not, like assistant about the funeral, the care of body, the transport, and the care of the family, explaining them, giving them empathy, giving them emotional support. If there are certain unused medication that should be written, so that their financial things also get addressed. whether the discharge summary and the death summary has been given or not, the death certificate after certain period has been issued or not, and bereavement support, which is very important. So these are certain pointers one should not miss. And after death care is very important part of end of life care. Then death news should be communicated early and in a very sensible way. The primary team should always be informed. Body laid down, as we discussed, in a proper manner. Proper presence and support to family, maintaining privacy and space, giving them a space for grieving and mourning can help. Timely and correct verification and certification of death, and timely and dignified transfer of deceased from the hospital and providing transport support may help. So then it comes the review of care process, which is a very important component of the steps involved in providing good end of life care. So one should understand if the care process was complete or not, whether there were any gaps which can be improved in your facility, whether the family received adequate time with you, they are satisfied or not, whether their adequate health related to communication has been maintained or not. One should be able to know whether the family fully understood and accept the care process. That is a very important component of reviewing your care process. One should know if the family had any concern regarding the care process, and that should be reflected and documented, and whether they were able to freely express, because some of the family, especially from the rural background, they can't optimally express the things to you. So we should be approaching to them and try to feel their concerns, to know if their family is felt supported or not, appreciated the care process or not. And most of the patient, believe me, in my experience, if we provide a good standard end of life care, they will be thankful to you. Like, say, losing a patient and saying thank in medical practice is very rare, and especially nowadays. But believe me, with good evidence-based practice, good communication, good symptom control, good communication, even after the losing a patient, family will say you thank you. So this will give you a level of satisfaction. And one also should be able to know the satisfaction of healthcare provider and all their any gaps that needs to be bridged. Especially you should talk to your nurses, your medical social workers, your counselors, your other allied healthcare staffs, your technicians, even talking to the your ambulance driver sometime also help. And believe me, this all care process will make your setup an ideal setup if you try to reflect on those issues. Bereavement support is very important part of end of life care. One should identify the high risk bereavement family and carers, and they should have access to a proper psychologist time to time if they are needed. The preliminary counseling should be done by the palliative care expert, and if they identify certain component of anxiety, depression, emotional distress, or exaggerated somatic symptom, they should connect to the counselors and clinical psychologist. And when needed, a psychiatric referral also helps in certain set of patients. So the infrastructure, I'm not going into very much detail, but one should have a proper hospital-based policy, proper staff, trained staff, and space, education and training when they are thinking about providing an ideal end-of-life care. There should be a proper storage and procurement facility for the documentation, and this document should be handled by the team involved in end-of-life care. And there should be standardized forms as per the norms of the hospital. Like NABH hospitals have different norm, the government hospital has different norm, the public hospitals can have the institutional policy and adopted documentation as per their institutional ethics committee. And certain kind of special support in form of chaplains, religious leaders. I won't call clinical psychologists as special support, because they are core component of providing end of life care. So they has to be involved from initiation. The contact details of funerals or undertakers, and the Mukti Dhams also help, because that reduces the actually the transport burden on the patient and their patient's family. So last but not the least, there are certain legal dilemmas, especially as far as the term passive euthanasia is concerned. This term has been globally obsolete, but still this term are being used in our court and legal documents. One should read the Arunava Sanwag case, how it was started, initiated, fell state, and these are certain to read list. Actually, I have this slide is for the student who want to go in depth about there are certain case based studies. One should read about the Common Cause versus Union of India judgment. One should also read the End of Life Care in India, a model legal framework by Vidhi legal firm. There are certain barriers of end of life care provision. There are legal limitations, physician limitations. Many doctors does not acknowledge, especially who doesn't work in palliative care setting. Especially they even want to go aggressive near the advanced and end of life care and during dying process. So it's our moral responsibility that as a palliative care physician we should advocate end of life care principles to our colleagues. And because these things are very new, this is not more than 40-year-old in our India, one should also try to find out what are the barriers in knowledge and infrastructure in their working setup, and there are certain family limitation, because these things are not just new for the lawmakers, the physician, or your administrators. This is also new for the families. They are not ready, so giving them a good time, good communication may help you for providing good end of life care. So these are certain must read subjects, articles or paper, you can say. The March 2020 AIMS guidelines on end of life care, the Blue Maple from Manipal hospitals, yes, ICMR draft paper on do not resuscitation, and illicit and Indian Chamber of Commerce document by the end of life care task force, which was released in August 19. So these are certain must read chapters for you. So I know I have been a bit fast, but these are the task has been delivered to you. Now it's your responsibility to go through those domains, those subjects, and these must read articles, and then you can actually strengthen about your knowledge about the end of life care. So this is all about core principle of end of life care. These are my contact details. For any type of doubt or any confusion or any clarification, you can connect to me. Thank you so much.